Um, Chairman, Your Excellencies, ladies and gentlemen, and the organizing committee, I thank you for inviting me for this presentation. This patient is actually from Gaza Strip. This patient is, just a second, presented to us from Gaza Strip to Jordan Hospital. And he was sent here out of desperation. And when he presented to us, he was 42 years old. He came in with a history of complicated case of pericarditis recurrent that necessitated at least 4 pericardiectomies, as he remembers. History taken from this patient was really very difficult. And this reminds me of a lecture that I gave in the United States when I used to go there 1 month and come back here for 1 month, where we do practice in the midst of plenty, and then we come in here, we do practice in the middle of like being in a desert with no water. And actually, we could do at times a lot more with these patients out of experience. So this represents of practicing medicine, giving the best kind of care where we don't have so many diagnostic things to be done, and many times with no history documented. So this patient developed paroxysmal atrial fibrillation that at the beginning was paroxysmal, then became sustained, then became permanent with time. And he was maintained on so many antiarrhythmic drugs. He was maintained on so many antiarrhythmic drugs, single or in combination, to no avail. He underwent probably at least 10 cardioversions without any success. So he progressively developed severe biatrial enlargement as per some of the mildly or sparsely documented reports, and he developed severe heart failure, and he was continuously the last 2 years in class 4 heart failure. And he was in class heart failure 4, NYHA, and probably between 3B, as we discussed today, in class 4. On top of that, his treatment was complicated with very low blood pressure that limited use of drugs to Cordarone, because he had atrial fibrillation with fast ventricular response. It was given as a rate-limiting medication rather than rhythm control, as well as digoxin. He could not tolerate any other drug lately. So he was on multiple diuretics at high doses, and combination resulted in recurrent significant electrolyte imbalance. He had a fast ventricular response to atrial fibrillation while sitting at bed, not moving, at a rate of 90 to 110 beats per minute, and with minimal motion, the heart rate will go to 170, 190 beats per minute. He had recurrent orthostatic syncope with associated bodily trauma, including multiple head lacerations. He had severe hepatic congestion with ascites and severe lower extremity edema. All of these were corrected before he came to us. His initial presentation, before that, just to mention, he had cardiac catheterization several times, and it revealed narrow coronary arteries, but no occlusion. And as he said, my arteries looked like hair. And all of this information not documented, it is taken from the patient. There was lots of desperation, frustrations, and patient developed psychiatric problem, and he was on multiple antidepressive drugs. The patient, the problem in Gaza Strip, as many know, there is no specialized hospital or specialized care, and this patient had all of his medical care in Gaza Strip or limited hospitals in Egypt, as he was involved with the Palestinian Hamas, and so his access to medical therapy was limited. After prolonged negotiation with authorities, both Palestine and Jordanian authorities, the patient was transferred to Jordan Hospital for management. And that's when we get consulted. And before transferring the patient to us, this patient was diarrhea so much, and amazingly creatinine stayed stable, and he came to us without ascites, without leg edema, however orthopneic, blood pressure 80 to 90, heart rate 110, 120, at rest, severe rest. Patient stayed in bed for 2 years, afraid to move, and however, his BNP was 170, creatinine normal, and he had hyponatremia, hypokalemia, and hypoalbuminemia, which were corrected for 5 days in order to get him out of warfarin and do some management if need be. So an echocardiogram with Doppler was done. I apologize that I don't have the echo recordings because it was not saved, and this happened like 5 months ago, and it revealed severe dilated cardiomyopathy, constrictive. He had estimated LV ejection fraction 25 to 30%. He had severe diffuse hypokinesis, and interventricular septum was moving with the right ventricular flea wall, denoting that he may have pulmonary hypertension. And also this contributed to decrease in left ventricular function. He had severe biatrial enlargement with the left atrium more than 6 centimeters. He had moderate RV enlargement with RVH and normal right ventricular ejection fraction. He had moderate to severe matter regurgitation, and it was central, and probably it was functional. He had moderate to severe TR, estimated RVSP 45 to 56, and he had a blood pressure of approximately 85, 90, 80 to 90. So he does have low perfusion body pressure. Despite that, he maintained a normal creatinine. And he had thick pericardium, but he did not have pericardial effusion. So we considered intervention for this patient. We did not know what we're going to do. However, 2 days before any intervention was done, this was his chest X-ray. As you can see, the heart reaches the left chest border. And as we know from his echocardiography, he had dilated LV and dilated right ventricle. However, the chest X-ray, as you look at it, it does not show that much congestion, and this documented by the BNP. So this was his electrocardiogram. Being electrophysiologist, probably I would comment on this more than some other imaging. As you can see, this is atrial fibrillation. R-wave progression is normal, axis is normal. It does not show LVH or any other thing to consider, despite the fact we show RVH, but I cannot see this on this electrocardiogram. This is the patient while semi-sitting, not moving, and this is his heart rate, despite the cortisone that I gave 3 days IV at 900 milligrams per day, so that I decrease his heart rate, which used to be to go up with emotions to 160 beats per minute. So this was at his best resting EKG, and he was ready for some intervention if need be. So if I may ask you at this point in time, just to show the either talking or show of the head, what will you do? Will you do a cardiac transplant at this point in time? Anybody? Raise hand. Why not? Okay. How about implanting LVAD? Also, why? Anybody? He is non-functional. He is sitting in bed, not moving, not this. Okay? Repeat pericardiectomy. He had 4 of those. And we don't have any hemodynamics that to show that this is actually the physiology that is putting in him state. Actually, it was suggested to him in Gaza Strip. Too risky to do anything. Stop fighting. And actually, I sat with the patient for 15 minutes. I took him to a room in hospital without any of the other team at the hospital and talked to him for 15 minutes about this. I told him, your case is almost terminal. I cannot do much with the resources that we have, with the resources you have in Gaza Strip. You're going back there, and we have to think about so many things. There could be something that I can do, but probably it is very serious. You could die on the table because I cannot put you flat with a blood pressure of 80 and low perfusion pressure, and we have to do a few things. And he said, if I have 1% chance of going through it, I will do it. But we'll talk about it. Do anything else? Any suggestion what can be done? Anybody? Ablation. What ablation? AF ablation. Good. Biatrial, left atrial, right atrial, biatrial, disjunction. Okay. We'll see about that. There is Dr. Marrouche in Utah University, and he had elegant work on atrial fibrosis with the how the disease progressed, and he had 4 classes, and actually that guided the atrial fibrillation, whether to do it or not, depending on how much fibrosis the atria have. Now we have biatrial enlargement, and probably the atrial fibrillation is so chronic, judging from the size of the atria, the pulmonary hypertension, and the total presentation. We don't have actually these sophisticated tests to be done, but the history tells us this. And I will talk about these 4 classes. Utah 1, and this is a classes meant or classified according to the amount of fibrosis that is picked up by MRI or other imaging, and then judging how much fibrosis in the atria will actually show how much success you can predict from atrial fibrillation ablation. Utah 1, minimal fibrosis, and this is 0 to 5% enhancement for the fibrosis, and Utah 2, 5 to 20% enhancement. Utah 3, 20 to 35%, and there is the diffuse and localized. And if it is localized, we may consider, we'll talk about it in a minute, ablation. And if it is Utah 4, it is hopeless. And in my judgment, this patient actually is in class Utah 4. So, and this is here other slide that discuss whether you may do atrial fibrillation or not as a recommendation by ACC and other associations. So Utah 1, you ablate. Utah 2, you may ablate, but you better have a good electrophysiology laboratory with lots of catheters and other things that you may need to do, which actually at this point in time we don't, maybe in 2 months. With Utah 3 localized fibrosis, you may consider ablation. However, if it is diffuse fibrosis, you may consider something as simple class 4. So this patient, if he's going to have any procedure that is left to him, is what? Rate control by ablate and pace. And the idea here is, as we can see here, this is the atria in fibrillation, this is the AV node, this is the His bundle, and there is the conduction system in down. And so the idea is you cut the AV node, maybe the His, maybe both, and then put a pacemaker. And preferably these patients need to have CRTP or CRTD. Now this is what I discussed with patient. This patient had 4 pericardiectomies. He had hair-thin coronary arteries as he describes them. And I don't know the status of the coronary veins. And I did not want to go to the lab, try to mess with the other things. I don't think the patient would have tolerated, and he could have died on the table. So the idea was, if we're going to do just one lead, he may decompensate, and we better do biventricular pacing. But I was ready to do it and see if I can get away with one lead by doing one maneuver. So we went to the EP lab. I visualized the left upper venous system to be sure that this was not disturbed by repeated surgeries. And then I tried to we decided to implant an ICD. Before we open the case to get the device, I just put single lead, the shotgun lead, and went up to the His bundle and tried to pace from there and to see if I can catch pacing from that area and achieve neurocomplex, and then will be great. Unfortunately, the pacing threshold was really high, so I did not do it, and then just went down 1 centimeter, and we achieved a great pacing threshold. When we paced, we got a QRS on the screen width of 134 milliseconds, and we thought this is good, because if we're going to develop cardiomyopathy, there is something called cardiomyopathy. If you pace from the ventricle all the time, more than 40% of the time pacing in the ventricle, patient may develop cardiomyopathy if QRS duration above 180 milliseconds. So we were lucky to achieve an area where the QRS duration is 134 milliseconds. And this is, so we decided to put a single chamber ICD, which is very easy to follow up in Gaza Strip. And this is how it looks on chest X-ray when patient got out. And this is the lead, the tip of the lead, which is at the high septum, just at the upper interventricular septum near the outflow tract. And then we tried to do AV node modification. We call it AV node ablation. And this is here where the catheter is, and this is here at the AV node area. And this one is in the LAO, and the other is the RAO projection. And we ablated there. I got accelerated junctional tachycardia at 110 beats per minute. So if I get the patient out and he is stimulated by his heart failure, there is no way I can pace. So we decided to go to the His bundle. So we went to the His bundle, and this catheter, ablation catheter, it has at the His bundle area. And we ablated there. I got only 30 seconds of success after several ablations, and the atrial fibrillation came back. There was one other thing to do, which is going vascular through the arterial system, go to the left ventricle, and then put underneath the aortic valve catheter in this area and ablate the His bundle. And actually, that was the easiest thing to do, because right heart was so much enlarged, there was no way I could put the catheter at the area of the AV node or the His bundle area. So 5 minutes, patient was pacer dependent. And so the procedure was terminated and patient was sent to his CCU. This was his electrocardiogram. And as you can see, it is narrowish pacing complex, and it is right axis reflecting it is at the high septum. And at the same time, it is at 80 beats per minute, because when you ablate, you have to go at this higher level to prevent ventricular fibrillation from happening. And the patient did well. After 5 days, on no cordarone, no digoxin, nothing. In 5 days, he was walking around the 3rd floor, going around, and not feeling that short of breath. Still was functional class 3, but he was ambulatory. When he goes to the bathroom, he felt good. By the 3rd day, he was laying down flat and sleeping, and it was a very impressive recovery. 2 months later, the patient presented.
Dr. Nazih, time.
Okay. So anyway, 2 months later, patient was seen, and his ejection fraction was 50%. The septum was moving with the free wall. There was minimal asynchrony. Patient was functional class 2, and the RV improved, and his PA pressure was less than 30 millimeters of mercury. Do I have any time for questions?
No, I think we're fine.
Any comment? Anybody? Just one? What's that? Normal. Actually 1.2. Okay.
Thank you very much.